So, I welcome you to the third part of our EEG curriculum. Last time we held this curriculum online. We forgot to press the recording button. So this is post-recorded EEG curriculum session. However, we hope that we will be able to give you insights into the topics of today's curriculum. The topics of this session today are the EEG in psychiatry, the historical and the current uses, and the objectives are again the main EEG parameters, so the parameters that are common and that have to be used in every EEG to rule out any pathological patterns. But before ruling out pathological patterns, it's important to define the normal patterns. So we talk about these parameters that define a normal EEG. And we discuss the topic when an EEG is needed or helpful, especially in psychiatry, of course. And we discuss the EEG's role in differential diagnosis, at least in some examples. And in the end, we had a case report. However, since this is a post-recorded session, I'm only going to show you some slides with EEG examples, but we don't have a full-blown EEG example as in the previous two sessions. However, we will be back in session 4 with online rating again. So don't forget, we also have our questions on the EEG and the quiz on the EEG and on the topics you learned today. So don't forget to log into that. So when do we do EEG in psychiatry at the moment? So it's important to know that we do an EEG at baseline for lithium and clozapine because these two drugs, they induce changes in the EEG and they could induce changes. So if you don't have a baseline EEG, it's hard to judge whether the changes come from either lithium or clozapine or if it's something else going on, for example, a delirium or some metabolic changes. So this is why we need a baseline EEG when introducing these two medications. Then we need an EEG if you have questions regarding the differential diagnostic process in panic attacks versus seizure detections, versus seizures and dissociations. So to rule out if there is a real seizure, a somatical seizure going on, epileptic seizure going on, you do an EEG during an attack. If you see a normal EEG, you most likely can rule out epilepsy, but you then have to do with either dissociations or maybe a panic attack. So you also could use the EEG for differential process for ruling out if there is, or not for ruling out, but for getting more information about the cognitive state of a person that suffers from depression. And in depression, we know a cognitive decrease called pseudodementia. That means you have a lowered cognitive ability during the depression, but this you will return to your abilities after depression is over. And this is a pseudodementia, and this is totally different than a real dementia, where there is a decay of cells and so on, and this is not reversible. So you can not rule out, but you can have some information on the ongoing process by looking at the EEG. For example, if you have a below 8 Hertz ground rhythm, basic rhythm, then you're highly likely that there is something going on that's not a pseudodementia, but a real metabolic or even other process that's going into a direction toward dementia. So this is why we need it for this differential diagnostic process. You of course do EEG if you have the clinic for seizures, for example during alcohol withdrawal, if you monitor, for example, the ECT sessions, and of course you need there the EEG, so you can see if the seizure is lasting long enough. We need those 30 seconds for each seizure, and so we are monitoring this during the seizure sessions. You need the EEG for the exclusion of organic causes of the symptoms, for example, in the initial manifestation of psychosis. You can see if there are slowings or epilepsy typical patterns. And you need it for delirious conditions. When you see someone is in a delirious state, you do an EEG to see whether the EEG reflects those changes or not. And we support any use of the EEG in cases of atypical presentation. That means the age doesn't fit to the onset of the symptoms, or you have a resistance to several approaches of therapy and so on. So then do an EEG to find out, maybe get some more information. We do in our hospital, we do EEG before doing any type of stimulation. That means before we put energy into the brain using electroconvulsive therapy, we measure what energy comes out of the brain. Okay, so this is common in all our other areas of the medicine. So to measure something before you do something, so we do the same in psychiatry. Before we do a TMS and influence the brain rhythms, we measure the brain rhythms to see what they are like, and we of course use them also to identify biomarkers. There are some on the horizon, so we get a biomarker sheet with recommendations for treatment for every EEG we get in our clinic. So this is the future, and we will address this topic later in our curriculum. So this was a long text. Let's get back to this description of the main parameters of the EEG. And here we have, again, the main parameters, which are the basic rhythm, the amplitude, the localization, morphology, the changes over time, and reagibility. We look at the vigilance, and we compare the results with earlier findings. For example, the baseline EEG when you dosed in clozapine or lithium. So then we get back to the description of the pathological activities. So there are two major kinds of pathological activity, if you want so. So there are some patterns that are clearly pathological, for example, the epilepsy typical patterns. And there are also some special patterns like triphasic waves and also the slowings. However, in EEG, sometimes you don't have pathological patterns in themselves, but the temporal sequence of those patterns might be pointing towards some pathological processes. For example, if you have a very fast decline of vigilance, in itself the patterns of declining vigilance and lower vigilance, they are not pathological, but if you see them occurring very fast or never occur at all during a long period, then something's going on. So in EEG you have those pathological patterns, and sometimes you have just a pathological like sequence of in itself normal patterns. All right, so let's start with the frequency. And again, this frequency is stated in hertz, which is the number of waves per second. So if you look at this picture over here, and I hope you can see my mouse arrow, you have 1 second in that range, and you have 1, 2. You see the positive is the downbeat 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 times. So this is 11 hertz, 11 hertz, 11 times per second, and this is the beta activity. This was the alpha activity that what you just saw, and this is the beta activity. So again, 1 second, and you see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20 or something like that. So around 20, which is between 16 and 25 or even a little bit higher. This is the beta activity. It's less in amplitude. I forgot to include the scale here, but it's low in amplitude normally than in alpha. So then we have the amplitude. This is a German text, but I'm gonna tell you what it's about. So the height of the amplitude of the EEG waves depends, of course, of the montage, not only, as we heard in the first curriculum, from the number of neurons that oscillate at the same frequency, but and the thickness of the skull, but also of the montage. So you see here one EEG with a quite high amplitude, or what high, so 50 microvolt in 1 second here over occipital cortex for the alpha, and here you see the same EEG 10 seconds and the grand average. So recorded again the average against every other electrode, or the bipolar montage where 2 electrodes always are referenced against each other. And you see that, of course, here at the F3 against TP9 has a much higher amplitude if you only look at F3 against all others. So that means that in general the F3 in comparison to all others has a lower amplitude, and TP9 might have a lower amplitude. So this means you have dependency of the montage from the amplitude. Then you have to look at the localization, of course, and this means that you see here the occipital alpha activities clearly. If you look at the CSD map, the current source density map, where this activity occurs and is sourced, it's occipitally on the left side, and then you can see the source imaging. We did that last time in the curriculum, and you see that this confirms our hypothesis of the occipital source of EEG alpha, and then you can also do that for slowings, but due to time reasons we just skip that. for today. And then you look at the morphology of the waves, and this is just a description. So you look, are they monophasic, biphasic, triphasic, or polyphasic waves? So that means how is the phases of the waves. And then you look if there are uniform patterns or rhythmic activity, or if there are polymorphic wave patterns during more arrhythmic activity. And here you see the example. So you got here a rhythmic activity with alpha, occipitally a dominant alpha activity. It's going up and down like spindling its way up and down in the amplitude, and it's very rhythmic. The main frequency does not change, although it's different in the different electrodes. But here, if you look at the downside picture, you see that this is an arrhythmic activity. You hear some large waves in the alpha range, some theta kicking in after, then some decronization, and here you even have some more rhythmic alpha, but only at some electrodes. So this is a very arrhythmic polyphasic pattern, while this is a very rhythmic and smooth pattern over here. So just for you to see the difference. And then we get to the complexes, and here we have the complex, the K complex. Maybe it's called because of knocking. So if you are drowsy and you hear a knock, then you have this K complex. However, it's some development out of the so-called vertex wave you're going to see later, which is also similar but less high in amplitude. The K complex has a negative rise, then a positive deflection, and then after this some fast spindling component, which is this. And if it occurs, you either wake up from the drowsiness, or if there's no alpha afterward but more drowsiness patterns, this indicates the sleep stage N2. We see the sleep stages later in the next week's curriculum. So this is the K complex. And then we need to look at the manifestations or the development over time. So this means how does your patterns evolve over time? And what is important is that you, for example, if you describe an EEG, you not only describe the ground rhythm or the basic rhythm of alpha, like you describe the basic rhythm of a heart, the beats per minute. So you do it in the ground rhythm of the EEG, but not only that, but also the type of manifestation. So if you have more than 60% or 2/3 of alpha activity all over the electrodes over time, you see it's a very strong alpha activity type. You have a medium range from 30 to 6%, or low occurrence of alpha activity when you have less than 30%. And so this is what you also describe, how often a pattern it occurs. Is it periodic or arrhythmic, or is it paroxysmal? So is it kicking in suddenly and then there's no rhythm behind it when it comes and goes? So this is what you have to describe. And then in the end, you have to describe the reactivity. That means the evocation of some rhythms due to some physiological maneuvers or blockades. That means you have the most important thing is the alpha maneuver. That means you open the eyes and there should be no alpha in the occipital sides. If you close your eyes, there's this hypersynchronization in the alpha range, what we just saw. This is a hallmark of the EEG resting state activity. And if you open the eyes, it should be gone. If it's not gone, that indicates that you're very drowsy, for example, or something else is going on. So this is what is the reactability, and here's this Berger effect, or we would more like to call it the alpha effect, because Hans Berger, although you recall the first EEG, maybe is not was not the very best person for humanity. So this is why we like to call that either alpha effect. So here you see the alpha activity. Then you have this opening of the eyes. You see it on this artifact on the frontal electrodes, and here you have the alpha blockage. So the eyes are open. The visual cortex is doing something else, and then you close the eyes again, and the alpha rhythm occurs back in most predominantly at the occipital sides. All right, so let's go to the pathological elements, and just be aware that we run through all these elements. This curriculum is just designed to give you an overview, and then we learn it with the cases we discuss in the upcoming weeks and months, and of course in your personal teaching with your supervisors. So there are the epilepsy typical patterns, and you see there the spikes. Spikes are quite high amplitude spikes within the time duration of 20 to 70 milliseconds. So if they are longer, there are no spikes. And there's here what you see. So this is 1 second, and this is clearly lower than 100 milliseconds or 70 milliseconds. So this is clear spike and you have a clear negative deflection in the beginning, and you know that for the different electrodes, sorry, I cut them off, they should change, of course, also the direction, and they should not be limited to just one electrode, because then it's, of course, a technical artifact, but it should occur in several electrodes and montages. So be aware, if you have a bipolar montage, that the spike should not be only in the electrode, for example, where F3 is involved, but also in other electrode pairs. So then you can be sure that this is something going on, not only on the technical side, but maybe in the brain. All right, so this is the spikes, and then you have the sharp waves. And here you see the sharp waves, which is a fast decline of activity or amplitude, and large amplitudes which are much higher than 50 microvolts, 70, 80, maybe 100 or even more microvolts should be there, and they should last quite a while, most often in the theta or in delta range, as you can see it over here. And again, it should occur over several electrodes. And then you have the polyspikes and wave complex, and here you see the spike and the wave complex. So you have a spike and then you have the waves again over several electrodes. And then we leave the epilepsy typical patterns and we look toward the slowings, which could occur, for example, as we heard, during dementia, or which could occur during medication with neuroleptics or with lithium, or during some delirious state, or which, this only occurs in the general slowing, and the focal slowing also most often assigned to some injury in the brain tissue due to, let's say, a tumor, some infection. There could be several reasons why in the focal area the brain is not working as fast as in other areas. And here you see over the P8 and TP10, so it's on the right side, located on the right side, O2, so parieto occipital, maybe a little bit temporally, you have for 2 seconds, and here most pronounced within 1 second, delta wave. So this is some kind of focal slowing. Again, it's intermittent because it does not occur all the time, but it's only there during some time. And then again, you can use here the source imaging, and you see here are the slowings. You make the envelope, and then you can see that when looking from up on the brain, so this is the right temporal parietal region over here, so this confirms our localization of this slowing. And then you have the generalized intermittent slowing again. Here we see this slowing that occurs. Here you have a quite fast activity, 1, 2, 3, 4, 5, 6, 7, 8, 9, so 9 hertz over here. So and if you look at that one, and from here, 1, 2, 3, 4, 5, 6, 7. So this is something at around 7. So this is slowing. Could be due to drowsiness, of course, but also could be, if it occurs more often, or generalized due to other reasons as soil dementia or some metabolic processes. And then we have some more specific and special patterns like triphasic waves, as you can see over here. So there are, of course, those clear 3 phases of these waves, and they are more specific and occur less often in psychiatric patients. However, it's good to know that other patterns are there, and there are a lot of more patterns. We don't take care about all of them today, but just to have you an overview of what could occur in the EEG. So where do you need it? For differential diagnostics. And one important thing is that we always say that there is this layer theory of Carl Jaspers, who says if you have the reason to diagnose a very, let's say, somatical disorder, and that means if you have a dementia with a decrease and decay of neurons, then you cannot say that this person has, for example, a neurotic disorder, or personality disorder, or psychosis, because you're one layer above all this, which if this is destroyed, it's not necessary to have a diagnostic at the sublayer. So if you have a psychosis again, then you're not allowed, or you should not state that there is a personality disorder as comorbidity, because everything is explained within the psychotic disorder, and the last layer, all those neurotic, what they then called neurotic disorders. So I tell you this because the EEG, of course, is a sign of very somatic disorder if you look at the specific patterns like for example the slowings or the epilepsy typical patterns. However, if you have other patterns like sequences of rapidly changing vigilance which are not in themselves pathological, then you're more likely to be in the second layer. That means you can have, or you can gain some information about, for example, um, um, psychosis or affective disorders. So here we use the EEG for differential diagnostic in this dissociative or psychogenic seizure versus epileptic seizures, and here we see an EEG example, and you see clear hypersynchronization between between all the different electrodes. So this means that there should be a real seizure going on. No one can fake this in the EEG. So on the other hand, if you see a clinical seizure and you record the EEG and you have the typical movements of the arms, for example, and clinically it looks like a seizure, but you have no corresponding activity of that in the EEG, then you are looking at a dissociative or psychogenic seizure. So of course you need it for the non-convalescent status epilepticus. That means you don't have the the typical motoric activity of a seizure there, but you have fluctuations in the consciousness, for example. Also after an ECT therapy. And this is a highly dangerous state because this means that there are seizures going on in the brain all the time, which could be lethal in the end eventually. So this is why we need to detect that, and this is where we do the EEG. And if you see partially those epileptic seizures in the EEG, then you have to treat them. And here you see an example from Mr. Pogarel, who I really admire due to his activity in the EEG field. He works at the Ludwig Maximilian University in Munich, and he does the EEG for all the patients who get to their hospital. And here's the baseline with the clear algorithm. And then you have this confused EEG after ECT. You see this these high waves in the delta range with a hypersynchronization, and which could mean that there is a status going on. And then you give some benzodiazepine, and you see this activity normalizes again, gets back to normal. And this means there was a convulsive state going on. Then we have this delirious state, and we can try to differentiate the delirious state from other states by using the EEG, and that could mean that you have some intoxication or some exogenous substances that could lead to delirious states, or you could have a delirious state in combination with dementia problems, or you could see that although the patient presents in a delirious state, you have a totally normal, let's say, alpha EEG that would rather point toward, let's say, for example, a catatonic symptom in schizophrenia. So here we have an example of a delirious state of a very complex patient with a status after stereotactic telotomy several years ago. However, there was a slowing rhythmic theta activity 7 to 6 hertz going on with quite high waves during a delirious state, and the patient was on lithium, and the lithium was stopped due to those newly occurring patterns and this delirious state. And then you see that the EEG 12 days after stopping already normalized, got back to 7 to 8, almost normal alpha activity. You see it here in the end, and then after 4 weeks you see that you have normal alpha activity, and this tells you that you did the right thing. So you could differentiate those intoxication by lithium and its effects on the brain by doing an EEG, and then knew that you are more you should maybe try to stop the lithium if this is clinically a good choice. However, this is why you don't treat an EEG by itself, but you always treat the patient, and you gain some additional information from the EEG, but you don't treat the EEG. Now another example. So this is the dementia case I told you beforehand. So it's the most important thing here is to look at the basic rhythm. If it's below 8 Hertz, and believe me, if you have it below 8 Hertz, something is wrong from the organical side. If you have a basic rhythm above 8 Hertz all the time, you're most likely to be in a quite good range concerning those dementia processes going on. So, I cannot go back. What is this? So now you only see the normal EEG, and I try to go back. This is not very good, so I cannot show you because it just switched the pages, and you see a overall slowing over all brain areas in the dementia, and you don't see any of those slowings, but a normal alpha EEG in the pseudo dementia, when you're more likely to see only depression with cognitive problems that will be reversed after you treat the depression with success. So there are different forms of dementia, Creutzfeldt-Jakob disease, vascular dementia, Alzheimer's dementia, and so on. The EEG can give you some clue about what is going on in the brain. So you see here the table from Pogarel again, which states some quite pathognomonical features of the EEG. However, be sure there's no real one pattern that tells you what is going on. Always take the EEG as an additional source of information. And then there are some signs for encephalopathies, which you sometimes could mistake for schizophrenia. And one sign here is the anti-N-metyl deaspartate receptor encephalitis with the so-called delta brush. So you have here the delta waves, and on the top of the waves, this is not artifacts. As you see, it's over several regions, and you have in the face of the mountain, so the peak, not the trough of the activity, shows its brushes in the beta or even gamma range, and these are so-called delta brushes, which could point toward those encephalopathies and not original schizophrenia. So now we learned quite a lot. I will leave you with that, and I see you next time when we talk about EEG vigilance and sleep EEG. And I hope you liked what we were talking about. If you have any questions, you can get back to us all the time, and don't forget to do the quiz at our channels. Thanks to Tobias Welt and Stefano Ferreira for their help, and see you next time. Bye bye.